Good morning. Good morning. Good morning. Good morning. We're going to get started in just a moment. If everyone can take your seats, we're ready. We are here and we are ready. Thank you all so much for being here. It is really, truly a pleasure to have you, to see your faces. Thank you for coming in person. My name is Shri Sankar. I'm a program director here. I work in this building in the Office of Global Health and Health Disparities, which is part of the National Institute of Neurological Disorders and Stroke, or NINDS. So we really like acronyms. We have to have acronyms because all of our names are too long. So you'll hear a lot, and you can always, ask a neighbor what that acronym means, or come back to us. So on behalf of the Workshop Planning Committee, I'd like to welcome you to NIH, and thank you for taking the time out of your schedules to come and contribute your insight and your expertise with the collective goal of advancing health equity and pain. This workshop is focused on 3 important elements to accomplish that goal from a research perspective: community engagement, multi-level interventions, and research collaborations. Our hope is by the time you walk away tomorrow afternoon, you'll have gained and shared expertise on these topics from your unique experience and perspective. The workshop is part of the NIH HEAL initiative. This is another acronym. HEAL stands for Helping to End Addiction Long Term. And the initiative is an NIH-wide effort to address the opioid epidemic, not only by addressing addiction, but by improving pain management and reducing pain and the risk of opioid use disorder by developing safe and effective pain treatment and prevention strategies to improve the quality of life for all people. Our workshop specifically sits within the cross-cutting area of health equity and pain management and equity in pain management. And that is to underscore the importance of those that experience health disparities and the need to improve pain management in particular populations. So, and Janelle will get back to you with defining health disparities in just a moment. So in the next slide, I want to do a land acknowledgement. We gratefully acknowledge the Native peoples on whose ancestral homelands we gather, and specifically the Piscataway people, as well as the diverse and vibrant Native communities who make their home here today. Okay, so this is the fun part for me because and I'm not going to get gushy about it, but I just want to say that this is a wonderful team we have here, and we're very excited that we've kind of pulled everyone together. And I'll start by introducing Janelle, which many of you already know, but before I start to introduce, let me just say one of the goals of the workshop was to create an in-person and discussion-based forum. So it's not a typical NIH workshop in that the goal is really to hear your voices, make sure that everyone has an opportunity to provide their perspective and expertise in a real intimate discussion-based forum. So because of that, we did not open this workshop widely to all NIH staff. We're not broadcasting it live. Parts of it are being recorded to be posted later with consent, but we will make sure that we get your input as we go through this entire process. Okay, so we wanted to create a less intimidating environment where the focus remains on the discussion between fellow panelists. And so now to introduce our NIH staff to you, we put pictures up so that you could see the faces around the room as you're in the discussions. In the breakout rooms, you'll know kind of who we are. And of course, there are bios in your folder so you can learn more about who everyone is. And also we have credentials here. It's another comment I wanted to make. We add credentials here not to really demonstrate the variety of expertise that we have. For example, in clinical psychology, pharmacology, pain disparities, nursing, community engagement, we have a lot of experience, but we don't display credentials to assume any hierarchy of perspective. So we really place equal value on the different expertise that shows up in different forms today. And we really want to emphasize that. So, okay, so I'm not going to tell long stories. I'm just going to say Janelle Letson is a health science policy analyst in the Office of Pain Policy and Planning. She's the co-lead on this workshop and has put in an immense amount of work from concept proposal, which we initiated back in September 2022, up until this very moment. She began planning this workshop with me not long after she joined NIH, and has been the soup to nuts organizer. I looked that up to make sure that that was accurate. It's very accurate. She is the soup to nuts organizer from researching and selecting panelists, working with the contractors on every detail and much more. And I know many of you know Janelle. So she's in good hands now. You don't have to be sad that she left. So, and then Katie Reichard. Katie, you want to stand up? Thank you. Katie is a AAAS Science Policy Fellow in our Office of Global Health and Health Disparities Office. She's championed and led many instrumental components of this workshop, including managing the breakout rooms and logistics, but really she's taken a serious interest and passion in ensuring the best experience for the lived experience experts. She's added unique first-time additions, including a person with lived experience orientation, office hours, quiet rooms, loaner laptops, and other accommodations for people that are here, especially people with lived experience of pain. And so we really thank her for that. Janet has helped with the PWLE orientations and provided additional assistance, and is also our connection to broader programs within NIH Heal, such as NIH Heal Connections. Okay, and then we have our fantastic NIH panel facilitators. So Marlene Peters-Lawrence will be facilitating the community engagement panel. Dr. Karen Kell, and I say doctor, I'll exchange them as I go along, multi-level interventions panel, and she is from the National Institute of Nursing Research. So I've added the acronyms here. Many of us are from NINDS, but we do have representation across the other ICs, and we really appreciate that expertise. And then we have Laura Wanner, who is also in the Office of Pain Policy and Planning, and she will be facilitating the Workforce and Collaborations panel. Okay, so the next slide shows more of our workshop planning committee. So you may see these faces. Rebecca Corley is a patient engagement strategist. She was also instrumental in helping. She is in the room. Rebecca, you can wave hi. We have Priska and Aruna. So we don't know exactly when they'll be joining us, but if they're here, they can wave. They're from the National Institute of Minority Health and Health Disparities. So as you can see, we really kind of worked to round out the expertise within NIH and think about how we can put together a successful group. And these are also representatives from the NIH Heal Initiative as well. We have wonderful panel assistants that are helping us today. So they will be in the breakout rooms, Naomi Booker, Andrew Wright, and Haijun Park. Haijun will actually be virtual, so you won't see her. She'll be there taking notes. And so Naomi in the community engagement, Andrew in multi-level interventions, and Haijun in the workforce. So we thank them for their time and effort. And then we have our NIH leadership. We're very fortunate to have wonderful supportive leaders at the helm of this all. Dr. Koroshetz will give his opening remarks in just a moment, the director of our institute. We also have the director of Office of Pain Policy and Planning, Dr. Linda Porter, and then Richard Benson, who is the director of our Office of Global Health and Health Disparities, and he is here. Can you wave hi, Richard? Thank you. So we're really delighted to have the support and the leadership. And we want to also give a shout out to our contract team, who's been helping us, of course, do all of the logistics. And we have a science writer present. And we also have another feature that we're very excited to bring to this workshop, which are graphic reporters from CN Colors. So we have Belinda Jackson, who is in the back now, Lucinda Levine. Yes, they're waving over there. And Lisa Nelson, the founder and CEO. Karina Nilsson will be joining online. So they will be participating in these keynotes to provide graphic reporting for those who consent. And then we will have each of them in the breakout rooms to also capture that discussion. Okay, so we're very excited, and that will be, you'll get to see a preview of their beautiful work and art tomorrow when we do the breakout, the report outs. All right, I'm almost done. So this is my last slide, and then I'll turn it over to Jenna. So this is the part where we can't really do justice to giving a full scope of the expertise and both the lived experience expertise and the research expertise in health equity, in pain, in community engagement, lived experience with pain across the lifespan. We really are extremely fortunate to have such a fantastic group representing these different panels. And so again, encourage you to meet each other, read your bios so that you know who you all are. We have keynotes that we'll be introducing shortly that are bolded here. And we also have lived experience experts, and their pictures are featured here because we, again, just want to give a shout out. We really aim to try to have equal amounts of lived experience experts as we did researchers, for pain and researchers for health equity. And, you know, it can be challenging, right? And we're learning along the way. So I think this is an avenue that NIH really wants to move into, where we do a better job representing lived experience experts, or making sure that they are represented. And we're learning how to do that every day. As like yesterday, we're just constantly learning. So we thank you for your time and your patience with us. So with that, I will turn it over to Janelle. Thank you.
Thank you, Sharice. And I do have to, before getting into kind of some of the background information, give a shout out, of course, to Sharice, because she has been a pioneer in this area. The whole reason we are having this workshop is because she started the Advancing Health Equity and Pain Management program, and she has just been a wonderful mentor to me. So thank you, Sharice. But in thinking about, you know, why are we here for this workshop and why is this workshop needed? We wanted to kind of just lay it out simply, is that pain disparities have lasted for way too long. And so we want to work with you all here over the next day and a half to think about solutions of how we can really create health equity in pain management. We're defining pain disparities as pain differences that harm socially disadvantaged populations compared to advantaged populations. And it's important to note that the social disadvantage stems from forms of social oppression like racism, classism, ableism, other types of systemic discrimination, and the way that they interact for people who hold those marginalized, multiple marginalized identities. NIH has several populations that they designate as those populations that experience health disparities. And this includes minoritized racial and ethnic groups, people with lower socioeconomic status, underserved rural communities, minoritized sexual and gender groups, and people with disabilities. So in moving from disparities, we want to move towards health equity. And what this means is it's the continual process of ensuring that all populations have optimal opportunities for the best health possible. And the way that health equity really works is in centering fairness, opportunity, quality, and social justice for all. So what it would look like is all populations have access to resources and opportunities that are in proportion with what their needs are. The major contributors to pain disparities are called social determinants of health. What this means is the non-medical factors that affect health. It's the conditions of where people are born, where they grow, live, work, and age. And they fall into several kind of buckets, at least the way that the federal government defines social determinants. So this includes things like education access and quality, healthcare access and quality, the person's neighborhood or their built environment, their kind of social support and community context, and then economic stability. These social determinants happen at different levels of society. So that's why in the title of this workshop, we really call out multi-level interventions, because we're thinking about the way that these different levels of society are structured. So kind of at the most microscopic level is the person living with pain. Getting a little broader from there are the people who they interact with. Even broader from that is where people get their care, where they live, and then of course those broader policies and general beliefs in society. So where pain interventions and research has usually happened, and this includes the kind of research and interventions for pain disparities, has been at this first level, or the smallest level of the person living with pain. And what we're hoping to do as part of this workshop is start thinking about moving beyond interventions that are at the person living with pain and thinking kind of at these bigger levels, because those are where those major contributors or social determinants of health really stem. So for example, a social determinant at the level of the people or the way that people interact with other people might be something like provider bias or even a lack of knowledge. something about where a person lives. Social determinants might be things like, are pain services offered in their neighborhood? So thinking about rural communities, is there access to acupuncture or other kinds of services there? We do want to acknowledge that a lot of progress has been made in this field, and many of the people in this room have been the thought leaders who have contributed to the body of work that we're building off of. And of course, we all know that more work is needed. And so that's why we're so thankful for all of you being here today to, well, today and tomorrow, to contribute to just more advancements. In the kind of ways that more kind of work is needed, we really thought about 3 sort of big picture gaps that are central to this workshop. So the first is that community engagement is really lacking across the field of pain. And so this means involving people with lived experience of pain, not just as research participants, but as research partners. So that means in planning, what the research question is to begin with, what the study design will look like, how the outcomes are interpreted and reported. And this is especially true for people from populations experiencing pain disparities. Another big picture gap is that interventions often target the individual and not necessarily those social determinants of pain. And then finally, to run research in this area, we really need to think about how we build the workforce, making sure that it's a diverse, inclusive, sustainable workforce, and strengthen the support that's needed there. So that leads us to the sort of overarching goals for this workshop. So the first is identifying ways that community engaged research can be done meaningfully with populations that experience pain disparities. So not just as a check mark, as part of requirements, but really authentically done so that community voices are embedded into the research study. Another goal for the workshop is to brainstorm what kinds of multi-level interventions are meaningful and actually doable. So, there might be some interventions that would work, but what kinds of interventions can we do that are actually possible and will move the needle towards health equity? And then finally, really thinking about how we can build and strengthen the workforce and diversify the workforce, thinking about what are sort of core competencies. And this means things like key skills, personality or personal attributes, and areas of knowledge that researchers, community partners, et cetera, need to build to be able to support a sustainable workforce in health equity and pain management. And to say it again, because we can't say it enough, we just are so appreciative of each and every one of you who are here over the next day and a half, and are just really looking forward to the discussion panels and the information that we'll learn from all of you. So thank you again. As Sharice noted at the very beginning, this is a bit of a unique workshop. And so the morning we have some presentations, but then the afternoon is very discussion based today. And so we just wanted to point out a few things that might help to create a safe and equitable space for discussion. So one, and this is a really key point, is that everyone in the room is an expert in their own way. And so we hope that kind of everyone keeps in mind just placing value and validating people's lived experiences and various perspectives. Also to try to minimize the use of jargon. We know in our presentation already we've used some jargon. So if you're going to use jargon, to try to just define it for everyone in the room in case there's someone who's unfamiliar. And to focus on critiquing ideas and issues versus critiquing people. Another point is to listen to understand, not just to reply. And this includes allowing others to speak without interrupting what they're saying. Assuming positive intentions, but also it's okay to acknowledge the impact, because we know that intentions and impact are not always the same. And of course, this is depending on what your level of comfort is in acknowledging that impact. And then finally, to keep the information private. So like Sharice said, we're not broadcasting the discussions from the panels that we'll have later today because we want people to feel comfortable talking about their lived experience. We don't want to have anyone feel uncomfortable in sharing those kinds of personal information. So just we ask you to keep that privacy beyond the workshop. And I will turn it over to Katie.
Hi all, I'm Katie, and I just wanted to go over a little bit of housekeeping. And I'll also add that the information relevant to where quiet rooms, restrooms, etc. are for your afternoon panels is also going to be printed out in a sheet in all of those rooms. So as that's needed, your panel facilitators and NIH staff of the room in that sheet of paper will help you find what you need. So relevant to that, we've reserved 3 quiet offices for access for needs for additional breaks. In each of those rooms, there's a sheet that gives information on how to access the Zoom, which is a non-recorded Zoom, but just a way for people who are taking breaks to be able to listen in so they don't miss the proceedings. Room 5248 has a loaner laptop that anyone, regardless of NIH account, is able to access to. And it's a very short Zoom link. I made a shortened URL, so you'll just have to open a browser and type it in, and you'll be able to access the proceedings of the room that you've left from. So just make sure you know the name of your panel and go into the panel that you are a part of. And again, as needed, please leave to the restroom. I have been a middle school teacher in the past, and I hope none of us have to give people permission to leave to the restroom, but please note that that is when you need it, as needed. The building also does have security, as you saw when you came in. This badge is your ID while you're here. Tomorrow you'll need to check in again, but need to bring the badge as well. But during the day, make sure that this is visible. This evening, the shuttles will bring folks back after the workshop to the Bethesdan. And in the Bethesdan, there's a restaurant called Fialova. This is a non-NIH sponsored space that we have reserved for you to be able to purchase using your per diem and spend time networking together. It will be open and reserved from 5 to 7 p.m. and there should be a sign in that space indicating where the gathering will happen. And so I hope to see some folks down there as you need. And again, this is non-required. So we all know some people get very burned out after a day like this. I know when I'm at workshops, I'm the one that orders food to their room. So as you feel comfortable. And then there are also in this space, particularly for folks who are in the workforce panel, the 6th floor is badge access only. So there will be a few of us, and we'll remind this when we move up to that space. If you are in the workforce and collaborations panel, there's no way to get into the 6th floor without a badge. So if you need to go to the 5th floor rest areas, you'll touch base with an NIH staff person who's in your room. You'll have my number accessible, and we can let you back in as needed, and we'll all move up to that space together. And as breaks are needed throughout the day. The 5th floor is open during regular working hours, but again, and we've let staff know on our NINDS team to expect folks who aren't typically there today, but just keep that badge on so people know. All right, thank you all for being here.
Okay, so it's now our pleasure to introduce our NINDS director, Dr. Walter Koroshetz. He's joining us today to show his support and leadership. And I won't give his full bio. I think that I just want to say that he's not only a leader at NINDS, so part of the NIHEAL initiative. He has been supporting not only our Office of Global Health and Health Disparities within NINDS, but also the Office of Pain Policy and Planning is under his home and in NINDS. And we really appreciate his leadership and support. So I will turn it over to you. Thanks, Walter.
Thank you, Cherise. Thanks, Chanel, and welcome everyone. I just start off by saying you're dealing with a very hard problem. We are dealing with a very hard problem, and we are looking forward to your input as we try and make some kind of progress against this really hard problem. The problem has a couple of different facets to it. We're going to be talking about health equity. And I think we have to acknowledge right off the bat that the system that is currently in place in the United States does not guarantee health equity, and in many instances works against health equity. So the system is one of the big problems. And you can try and work to change the system, which I would encourage. But I think as that is going to take time, we have to learn how to work around the system to improve health equity as well. So I encourage you to be cognizant about what is practical, what's going to make a difference for people who are suffering with pain. Now, that's true about all the diseases that we take care of here at NINDS. It's true about all the other diseases and conditions that are taken care of across NIH, that we're always striving for improving health equity. But we are research institutes. So what we do is the research that identifies pathways that can improve, in this case, health equity for pain. But the idea that that research, when we have findings that are, that those findings will inform healthcare. So the ultimate goal is to get that football across the goal line, and that is improving pain care for people. And everything else is preparatory to that. So I think you want to keep that goal in mind, and you want to keep the people who have pain in mind and the conditions that they have as you start to think about this. Now, the HEAL initiative is this overall program that's been funded by Congress, and it was in response to the overdose crisis from opioids, which started due to overprescribing of opioids for people who had pain or thought they had pain or wanted opioids and didn't have pain. So that's how it started. And unfortunately, it got completely out of control. And now what's happened is people who have pain have trouble getting their pain controlled, and they move towards street drugs to get their pain control. And in addition, in this country, we fuel this gigantic illegal trade system for illegal drugs, which is now targeting people right out of high schools, as opposed to the initial problem was targeting people who had pain and were on prescription opioids. So the problem of pain and opioids are really tied closely together. And I think we have to be cognizant of that as we move forward today as well, for a couple of reasons. So if you think about why that is, I would just give you a simple view of how the brain works. Our brains are engineered over millions and millions of years for two simplified purposes. One is to go and achieve the rewards that are needed, and that's, basic needs: feed, food, procreation, and all the other, fulfilling activities that give our brain a sense of reward. On the other hand, the pain system is put together to keep us and every animal that exists away from a injurious event. And both those systems are incredibly powerful drivers. And so the problem with opioids is that they work on the pain system. They also increase the reward system. So once you get involved in trying to use those medications, you run the risks of driving your brain towards reward for opioids, and that potentially taking over your life. And so the management of pain has to take into fact that what we're trying to do is to bring people to their highest functional level, given the tools that we have available. And so in some people that does require opioids, and it requires judicious use of them. In some people, there's no evidence that opioids actually work, which then runs into another problem we have in our health system, is that we don't really have great tools for certain types of pain. Acute pain, opioids work very wonderfully for a short period of time. Chronic pain, there's rarely any evidence that they actually work at all. And in fact, there's evidence that if you take opioids chronically for chronic pain, your chronic pain is actually worse because as the opioids leave the system, your reward level drops and your pain level rises. So that's where the HEAL initiative was instituted, to try to help negotiate the best pain management, knowing the risks of opioids. Now, and that's what the HEAL initiative is central to. And what we try to do in the HEAL initiative is to not only develop better treatments for pain that are non-addictive, we're also trying to help people manage pain in a more effective manner with lower risk of addiction. So that's central to what HEAL is. And so there's a very strong work going on the pain side. There's very strong work going on the opioid overuse side. And there's a lot of interactions between those two pieces. If you think about it, people with chronic pain who are taking opioids, that really is a cross-cutting situation. People who have opioid overuse disorder and they develop pain, they break their leg. Well, how do you manage people pain when they have opioid overuse disorder? Those are really tough problems. Now, that's kind of the problem set that we're dealing with in the HEAL initiative. But today we're going to be talking about the fact that the problem is a hard problem, but it's worse in certain regions of the country for certain people. And that leads to disparities in getting to the best possible treatment for your pain. Now, this is, I don't know how many people have had really bad pain, but if you've ever had really bad pain, you'll do almost anything to make it go away. It takes over your brain. You can't think. You can't interact with other people. It completely shuts you down. And that's because this pain system we have is so strong. And it gets out of control in certain instances. So it's common. We have all had pain. We do surveys, and the CDC does these kind of surveys. The incidence of chronic pain is very high. It's running in the 30% range. And then there's a certain percent of those people who have what's called high impact chronic pain. So every day they have bad pain that prevents them from doing what they would like to do in their life. So disabling pain. These folks also are not suffering from pain in isolation. When you look at this group, these people are the sickest people in the country. They have heart disease, they have COPD, they have osteoarthritis, they have cancer, they have stroke. So the point about this is that these are actually some of the most vulnerable people because they have such a combination of conditions that they find it really hard to get the kind of care they need. The other part about pain, which I think we have to be really honest about, is that pain is not something, you know, if you have a broken leg and you see the broken leg, okay, there, you know the pain. If you have chronic pain, daily chronic pain, there's usually nothing to see. You can't go in and say, you know, take an x-ray of my pain. Okay, we saw the pain. Here's, it's a subjective experience. Pain is a personal experience. People react differently to the same kind of pain stimuli. And that's because we have in our nervous system, we have detectors for pain, which we call the nociceptive part. But that's really not what causes the suffering. The suffering is caused by the circuits in the brain that put such a high valence on these nociceptives coming in, such that you can't do anything else. And so there's the perception of pain, which is separate or tied, not kind of separate, but different from just the feeling, you know, of a pinch. There's also a circuit that brings that valence so high that it takes over your entire brain. And that's different in different people and maybe different in different cultures. There may be lots of things that affect the perception of pain. Particularly, I would tell you that certainly in depression, pain is significantly elevated. People have depression. But the point of it is that in order to manage pain, there really has to be a one-to-one relationship with the person, because it's a personal experience that we're trying to help them with. It's not like a cancer or your blood pressure, population type thing. This is a real personal experience. And that means that to do the right thing really takes a system where there's a lot of human interaction in managing the pain. And our current healthcare system doesn't pay for that. And that's one of the big problems. So most of the pain clinics in the US now are run, and they're run on the economics of doing nerve blocks and interventions to reduce pain in certain conditions. But if you're not in that category, those clinics don't offer you a lot. And so pain care in the US is a real problem. Pain care, and because it's not well remunerated, pain care in disadvantaged populations is really way under satisfactory. And the other point to know is that, as I was mentioning before, that you can't see pain on an X-ray. It's a subjective report. So people's biases come in when someone reports pain. Some people, and there's a lot of stigma about pain. Some people think that patients who have chronic pain are not functioning, are lazy, or they don't want to do anything. So they say they have pain, but really they don't have pain. So there's no painometer that you can dial up and say, oh, that person has this much pain, that much pain. You have to have this conversation, really understand the person. The other problem, which is related to the opioids, is that there are, I'm sure it's a minority of people, but there are people who are seeking drugs and they're complaining of pain so that they can get drugs. So people presenting to hospitals, one thing that might come up right away is that somebody walks in the doctor's office, this person drug seeking. Why do they think that about that person? Well, there might be a lot of biases that go into who they have high suspicions of, who they have low suspicions of, and so pain has an added level of bias than many of the other conditions in the healthcare system, and so that's something I think that might be a target for research to try to prove that problem. So I'd urge you today to think about, the people who have the pain. Always keep that in mind. And the goal is to try to develop research that's going to inform how we can better take care of folks like that. Now, how to do that, I think this is a hard problem. I think some of the things that we've been thinking about in the HEAL initiative is going in a separate direction from the usual medical system, but actually engaging people in communities to work in their communities and maybe work with the physicians and the academicians. But I think there's really powerful advice and lessons that can come from people who've had chronic pain or people who've had opioid use disorder. And their messages may be more powerful and more impactful than, say, a physician and a nurse giving somebody a lecture. So moving more towards engagement of people with lived experience is one thing that we think is worth exploring, certainly in many spaces, but certainly in this space. So I'd like to urge you to, think practically, try to give us good advice, think creatively about what can be done for this problem, but be very realistic, because this is, again, as I mentioned, a really difficult problem. It requires really clever thinking, and I think the good news is the HEAL initiative is really devoted to try and make a difference here. So we have and we will be putting resources into trying to make a dent in this problem. So I appreciate all your hard work, and no pressure, but we need some solutions from you guys by tomorrow. All right, thanks very much. Oh, and very good. All right, so. Okay, now I'm pleased to introduce our next speaker, Dr. Burrell Gooden. His presentation is entitled "Do Social Determinants of Health Promote Pain Disparities?" He's a professor of anesthesiology at WashU in St. Louis, 2024's president-elect for the U.S. Association of Study of Pain. And he was spent 11 years at University of Alabama at Birmingham. We rank a professor of psychology and co-directed the Center for Addiction Pain Prevention Intervention. We've talked in the past, and there's no better person to get you guys going today. So great, Burrell, take over.
Good to see you. Thank you, my friend. Do I just advance the slide using arrows? All good? All right, cool. All right. Yeah, I was gonna have some of that. Okay, all right. So fantastic. Great to see you all this morning. I'm very excited for this workshop. Initially, I wasn't entirely sure what to expect, but I can tell you that when Charisse and Janelle asked me to do something, you can count me in. And I would encourage y'all to take that same sort of approach because you end up getting to interact with some great folks. So, okay, so do social determinants of health promote pain inequities? And Janelle spoke a little bit about what these sort of terms represent. And you'll notice in this title that I said pain inequities and not disparities. And the reason for that is I think there's some important differences there in that nomenclature such that, you know, disparity, if you just look that up in the dictionary, is just the difference or a lack of parity, right? And in my mind, a disparity isn't necessarily undesirable in itself unless it is the result of some sort of unfairness or some sort of unjust consequence. So what I mean by that is, for example, is that there may be differences in sort of different ethnicities or races in terms of how they experience pain that may be due to cultural differences in how they make meaning of said pain, right? And that's not inherently a problem. We don't want to eradicate that cultural difference. We want to embrace it and understand it so that way we might be able to then better utilize it to inform people-informed care, correct? However, the inequity, in my mind, then, is a state of being unfair. And in that regard, it's always undesirable and subject to moral criticism. And that is where we need to be able to focus our efforts to eradicate those inequities and those injustices. So, for example, that would be differences in people's experiences of pain or the treatments they receive therein as a function of being discriminated against or the biases that come into play a lot of times, as Walter was just alluding to. So I will say this, as Walter mentioned, so the brain over the years has developed this pain system that is intact to be able to recognize something that is threatening and may cause us pain. So when you see the stove on and it's hot and it's beet red, you're like, okay, I ain't gonna touch that because that's gonna hurt, right? So way back when that pain system was developing, perhaps, you know, people were sort of nomadic and living in caves and sort of rolling solo. But over the years, they became way more social because that's in our favor to come together and form a community, farming and sharing sort of, you know, child rearing and things of that nature. So in an effort to become more social, the brain also was like, well, there's something with this pain system. Let's just tap into that such that when things are socially cohesive, that's a good thing. But when things are socially threatening, it can ultimately be a problem in terms of your well-being, but can also promote pain because there's a lot of shared neurobiological underpinnings there. And I won't go too far into that neuroscience or that neurobiology, but ultimately social threat and physical threat can both promote pain. So coming from that in terms of social determinants of health and domains that can promote pain inequities, I like to come at it a multifaceted way. And there's a lot of different rubrics that have been put out there by NIMHD and NIA, where you can see in the little schematic there, things related to economic stability, the neighborhood and built environment you live in, education, educational access, quality of education that people obtain, access to food, and then there's the community piece there with the safety and the social context, and then the healthcare system. While the research that I've been doing kind of taps into all of that, where I really want to focus today, just to sort of show you some things, is the sociodemographic piece, that built environment, and then interpersonal. This is an interesting piece here as it relates to the biopsychosocial model of pain, which I think we can all pay homage to, and recognizing that the biological and the psychological has received a lot more attention in the last decade or so than the social piece has. So in my mind, the social piece is an area for increased investigation, as there is likely to be untapped potential there to inform the next generation of person-centric pain treatments. So as also Walter said, I'm recently relocated to the St. Louis area in Washington University. Prior to that, I was in Birmingham, Alabama for 11 years. So these data that I'm about to show you are all basically Birminghamians, right? And those lovely people from Birmingham and Jefferson County, which is what this map represents. The point here is place matters. So on the left, what you will see is a schematic of dots representing households. And the red dots are white households, the blue dots are black households, with a smattering of green representing Hispanic households and yellow representing Asian households. So primarily blue and red representing white and black households. And you will see that those households are not integrated. There is some segregation here, such that the red dots are where the white households tend to be, which would be called sort of over the mountain. So that's leaving the city proper and going over into the more affluent suburbs. And when I say affluent, you can really appreciate that when you look on the right. The different colors of green there represent areas of poverty versus affluence, with the darkest green representing the most impoverished. And if you were to superimpose those maps over the top of each other, what you would see is that the majority of the poverty rests within the black households within Jefferson County. So place matters. So some of this research here was just looking at differences in chronic low back pain severity between white and black individuals. And there's a difference such that the burden of that low back pain tends to disproportionately affect the black individuals. But my question is that if we stratify that a little bit more as a function of economic insecurity, which we defined as individuals living below the poverty line, which is a function of annual household income relative to number of people living in the household. And then you compare that to the current year sort of Health and Human Services guidelines for what represents poverty, as well as employment status, right? Where people unemployed versus employed, and within the employed could be retired if there's a pension or some sort of IRA that people are living off of from previously being employed. So ultimately, looking at people who are economically insecure, and you can see that it sort of parses out even further when we ask people to do this behavioral activity, which is meant to mimic sort of real world functioning with low back pain, getting in and out of bed, standing up from a chair, sitting back down, lifting a crate from the floor to the table, and the pain that evokes, such that ultimately then the black bar represents those black individuals with economic insecurity. And you can see that their ratings of pain from these behavioral tasks are the greatest, the absolute greatest, and their ratings of how difficult it is to actually perform said tasks also the greatest, right? Okay, so then we start getting into, all right, well, these folks live in neighborhoods. And as I showed you from those previous maps, excuse me, some of these neighborhoods are more affluent and places where we might envision the American dream unfolding, right? And other places are not that, unfortunately. And there becomes an inequity that is sort of pervasive throughout all health conditions. We just so happen to be talking about pain here today. So what I want to show you here under that sort of domain of the built environment is some work from a PhD student, now faculty at UAB. And I say PhD student, she was actually Dr. Edwin Aroki's PhD student, very bright scientist, Pam Jackson, who used the neighborhood atlas. If you're familiar with this was some work done by Amy Kind at Wisconsin that really used like geocoding and census tract to sort of map out using sort of a heat map of more sort of relative neighborhood deprivation versus affluence. And if you look at the bottom left across America, it gets way more granular. You can go into neighborhoods and see this heat map, but ultimately those in blue are the least disadvantaged. Those in red are the most disadvantaged. So you can see a lot of that in the South and the Great Plains areas, where the disadvantage is most pervasive, and then more coastally, you'll see that there's more affluence. But then again, even within, like, say, a place like Birmingham, this tends to play out as a function of those maps I was just showing you, where those white neighborhoods over the mountain are more affluent and least deprived, where the inner city neighborhoods, you know, are the most deprived, and folks have the least amount of socioeconomic resources. Oh, sorry. And then ultimately what Pam showed here on the right, that bar graph, is that individuals who are experiencing the greatest degree of disability because of their chronic low back pain also tended to live in the most disadvantaged neighborhoods. All right, so that's the take home from that slide. So now, speaking about Dr. Edwin Oroki, fabulous collaborator. It's been a pleasure working with him for the last, I don't know, whatever it's been, 6-7 years. Edwin's question has been, well, how do these sort of social and environmental factors sort of get under the skin to really affect disparities between white and black individuals with chronic pain? And this is sort of his most seminal sort of review work here, sort of showing how, say, a white child born in a specific neighborhood relative to a black child born in a more deprived neighborhood may experience comparable sorts of lived experiences to get started, right? But then as a function of their upbringing, and again, the driving force with the research I do, the stuff that Edwin does, is that race is a social construct, right? We're all born equally, but unfortunately, we don't necessarily stay that way. And that's a function of things related to the household you're born in, the neighborhood you're born in, the resources you do or don't have access to. And then within those neighborhoods, things related to like violence and racism and over policing versus, you know, good school systems and after school programming. That affects your epigenetics, that's the next slide, but ultimately in ways that can then confer sort of resilience or vulnerability to things like developing chronic pain, such that in this paper, as Edwin was alluding to, white child, black child grow up, and due to differential exposures and experiences, the black individual may have debilitating chronic pain and depression, where the white individual just deals with a little bit of mild pain, is otherwise good and happy and going on with their life. Epigenetics, honestly, if you want a really good tutorial, you got to go talk to Edwin. I know just enough to get through this slide. Okay, so don't hold that against me. But the fact is the DNA you're born with is the DNA you die with, and that doesn't change. Okay. However, DNA can be expressed or not to yield proteins that inform and basically contribute to every human function that we do. Right. So epigenetics are little things that can modify the genome, but they don't actually modify your DNA sequence. So what we often will study are things like DNA methylation, which are just little methyl groups that can attach to the strand of DNA to ultimately make it such that the gene could be inactivated and it's no longer expressed. So it can be turned on or turned off. So the good news here is that you're not one-to-one a function of your DNA. So you're not doomed, so to speak, right? However, as a function of the health behaviors and the experiences you have in this world, you can actually do yourself a favor or not, so to speak. And I say do yourself a favor, that's probably not the right terminology. It can either work for you or against you, so to speak, such that genes can be turned on and turned off. But this is a way of linking environmental exposures to gene expression and disease development, right? And ultimately, moving forward with this then, is that people smarter than I have started to look at physiologically things like DNA methylation to get an idea of physiological aging or biological aging relative to your chronological age. So chronological age, that's all of us. It's just an interval of time since birth. Somebody decided 365 days is a year, and then we all have a number of those years, right? However, your chronological age may not accurately reflect your actual sort of physiological aging process. The biological age is, again, that physiology, how your DNA is being expressed, creating proteins that confer health or vulnerability. And in the context of epigenetics, we're just looking specifically at these methyl markers, right? We can create I say we, again, people smarter than I, create these epigenetic clocks. And ultimately, what you can sort of look at and appreciate is a person sort of physiologically aging at a rate that's consistent with chronology and that might be considered normal aging. If you know, are engaging in good, healthful behaviors, and you were fortunate enough to grow up in these really like nice neighborhoods, you might have age deceleration, right? And that's folks who, you know, look a certain age and you're like, well, how old are you? And they tell you, like, dang, you look young, right? That's not me. You get people with sort of the age acceleration, this might be more me, where ultimately their chronological age is one thing, but their physiological age is outpacing that, right? And that's where it could potentially be an issue. Harkening back to Pam Jackson here and a nice little award that she got to inform her dissertation, her question was, might this sort of epigenetic age acceleration link neighborhood disadvantage with chronic low back pain? And the short answer is yes, it appears as if that's a possibility. And again, this is work that's been ongoing with myself and Dr. Aroki and Dr. Jackson, such that, and if you look at the little schematic here, basically what this is saying is that greater amounts of neighborhood deprivation where people are growing up and living and spending their lives relates to having more of this age acceleration. So perhaps your biology is outpacing your chronology. And then as a result, your pain severity is greater, okay? So this might be sort of one way such that the social aspect can sort of get under the skin, if you will, to affect the biological and then ultimately the expression of pain conditions like chronic low back pain. Shifting gears a little bit, HIV is a chronic illness. So I do a lot of work with folks with HIV. And when you speak about intersectional sort of identities and intersectional vulnerabilities as it relates to being stigmatized or discriminated against, people with HIV often take a hard hit, right? So people with HIV can live long lives now, you know, in light of the 90-90-90 if they're getting tested and detected and then put on their antiretrovirals and then achieving viral suppression. That's the 90-90-90 initiative. And the thing is that if that diagnosis happens fast enough, the medications are onboarded fast enough, viral suppression is achieved fast enough, folks can actually have a life expectancy that very much is in line with anybody else. Now, living longer does not necessarily mean living better, right? So that was where some of this idea of like a fourth 90 came into play about like, how do we improve quality of life for these individuals, right? Because there's a lot of health comorbidity that pops up. And particularly things that we've been interested in have been pain and sleep disorders, particularly underappreciated and undertreated. Because even when you look at like an institute like NHLBI and see sort of what comorbidities they say that they list as like high priority research as it relates to their HIV guidelines, like pain and sleep aren't even mentioned, right? It's more cardiovascular, kidney, whole organ type stuff. But what I can tell you here is that people with HIV who actually have a diagnosed bona fide insomnia disorder, so a sleep disorder, right? That's the red bar here, are reporting not only the worst sort of subjective insomnia severity, they're also on the right showing the actual worst sort of sleep efficiency, which is a marker sort of more objectively. They wear these watches, go to bed every night. Their sleep efficiency is the worst. So that means that the amount of time they spend in bed relative to the amount of time in bed actually sleeping is low. You'd like for it to be sort of at least 80% or greater, and theirs is in like between 70 and 75. So they spend a lot of time in bed trying to obtain sleep, but not a lot of time in bed actually sleeping. So low sleep efficiency. So sleep quality is poor. Where this perhaps becomes a problem for pain is that they also then show the greatest amount of pain sensitivity when we expose them to these different sort of standardized pain tests in a laboratory environment, heat and pressure. I won't go too much into that because it's technical and jargony, right? But the point is that if I expose somebody to a noxious, painful heat or a noxious, painful bit of pressure, what you'll see in the top left is that red bar, that's HIV positive and insomnia positive. And they're showing the greatest amount of sort of temporal summation, we call it. It's pain facilitation to a mechanical stimulus. On the bottom, same sort of deal with repeated exposures to cold water. That red line is like the absolute highest degree of pain sensitivity for those individuals with HIV and insomnia. And then on the top right, their ability to sort of inhibit pain, they're the ones all the way far on the left is the most impaired, okay? So you might say, well, how does this relate to anything social, Burl? And I'll tell you here in a moment. But ultimately, this is a question related to like how much bodily pain have you had in the last week? How severe has it been? And on the far left, you can see those individuals with HIV and insomnia are reporting the highest severity of bodily pain in the past week, such that a full 50% of that group was like, yeah, it's severe, very severe. Where if you compare that to the HIV negative and insomnia negative group, none of them reported any sort of severe pain, right? So the people with HIV are struggling with pain. If they have a sleep disorder, it's even worse. This is some work that is currently being brought to bear by a PhD student of mine at UAB, who is interested in looking, well, how does stigma, being stigmatized, affect this? So the red wording in the middle is basically the take-home message. But ultimately, we ask people with HIV, right, and chronic pain, how much do you feel like you get stigmatized for each one of those health conditions? Okay. And people who were sort of high on both, we consider that to be the high intersectional stigma piece. If they were low on both, then that's low. And if they were high on one, but maybe low on the other, then that's considered moderate. Again, not the most sophisticated approach, but you get the idea, right? But the point being is those individuals who experience a high degree of stigma because of their chronic pain condition, because of their HIV status. And again, that stigma kind of manifests as Walter was alluding to, perhaps being invalidated. Like, is this really something going on here? Are you just trying to get good drugs? Are you trying to get out of your chores, or you're working light duty? We don't really believe you, right? Those individuals who reported those experiences, the far left, the most depressive symptoms, the middle, the highest degree of insomnia and sleep impairment, and the right, the highest degree of pain severity, okay? So we're talking about sleep and pain here in the context of HIV, and at least in part, it may all be driven by these negative social encounters that people have interpersonally and interactionally on the day-to-day. Well, you know, how can we go about perhaps improving something? And again, I don't know if this is equitable per se. In my mind, it is. The gold standard behaviorally for a sleep disorder is cognitive behavioral therapy for insomnia. And if you're a clinical psychologist like I am, you may know that. If not, take my word for it. That being said, it's hard to access, right? It might take 10, 12 sessions, an hour a pop that happens over 20 weeks. I have all the resources in the world, and I don't even want to do that, right? So again, you can see how that throws up a huge barrier. Brief behavioral therapy for insomnia is born out of CBTI, but really it can be done in 4 sessions, once per week, 30 minutes a pop over the telephone, okay? And the 2 key pieces here are just stimulus control. So again, the bed in the bedroom used for 2 things, right? Sleep and sex, and that's it, okay? And it's creating a more sort of harmonious relationship with your bed so that you're sleeping. But then the other thing is sleep restriction, which paradoxically sounds weird, but it's sleeping less to sleep better. And ultimately what that means is that if you have that sleep efficiency piece where you're spending all this time in bed but not sleeping a lot, your wake up time stays your wake up time, but your bedtime gets extended such that you're struggling, but you finally go to bed and then sleep an entire amount of consolidated time. So it might only be 4 hours to begin with, but you sleep, right? And then you back off. So anyways, that's BBTI, meant to be sort of more equitable in terms of it being more accessible such that we bring the treatment to the patient via telephone, right? Wanted to compare it against a comparable brief mindfulness therapy, because right now, if you study mindfulness, mindfulness cures everything. So we wanted that to be an active control, right? Does it actually do anything here for these folks? And the point being is that some of this work was led by, again, lovely collaborators, Cesar Gonzalez and Shamika Cody. But what you can see right there in the graph is that from pre-intervention to post-intervention, again, 4 weeks, just one session per week, and then a 1-month follow-up, the blue line is that people's responses to the insomnia severity index, how bad their sleep is, drastically improved, okay? In terms of the mindfulness, it didn't really do much for this particular population, right? So BBTI improved sleep by decreasing the insomnia severity, while the mindfulness did not, right? And that improvement remained 1 month after the treatment ended. Well, that's cool, but these people also have chronic pain. Did we see any benefits there? And the answer is yes. On the left, we saw that there was about a point reduction on a 0 to 10 scale in their pain severity. and about a 2-point reduction in pain interference. That's the blue line there relative to the red. So, okay, so might improving sleep get you more bang for your buck by also sort of having downstream positive impacts on people's experiences of pain. That's fantastic. So we're flushing this out and trying to see where we can go with it. We've had some conversations. But anyways, some of the work that was also born out of this HIV stuff was the fact that, like, when we were recruiting our individuals with HIV, without even really trying, we looked and we were like, wow, we have 7 trans women who enrolled in this project. I'm wondering if, like, we can look at some stuff there, because as folks may know, there is a large literature about sex differences, right? Males versus females in animal models and then in people, such that across the board, it's often the case that females are more sensitive to pain stimuli and develop pain conditions at a greater clip than males, right? But what about transgender individuals, right? So this is something that, you know, we wanted to sort of appreciate, get into, building out sort of our disparities portfolio. It's new space for me. I'm trying to be exquisitely humble and sensitive here while I learn, make mistakes, people correct me as well they should, and then we move forward, right? But this was some work done by Larissa, where you can see we had 24 cis men, 20 cis women, and then 7 trans women, who 5 of whom happened to be on hormone replacement therapy. But these were all Black individuals living below the poverty line, again, in the Birmingham area. This is a busy slide, but all I really want to show you is that when we exposed individuals to a repeated heat stimulus, that's the left, right? What you see is that the purple dots are the trans women, the red dots are the cis women. These are individuals who identify as women, and they're tracking each other, like almost superimposed. Obviously, there's a little bit of space, but you get my point. And they're both way more pain sensitive than the men. That's the blue. Okay. So, excuse me. Then the question becomes on the right, well, what correlates with that pain sensitivity? Discriminatory experiences significantly, and again, this was a small number of people, only 7, but discriminatory experiences were well correlated with this pain sensitivity for these transgender women, where those experiences, as minimal as they likely were, weren't correlated at all with the cisgender men and women, right? But the moral of this is, like, if you've been, you know, affiliated with NIH work or go to an NIH study section and it's sex is a biological variable, okay, cool, but what about gender as identity? Okay, so maybe there's the next level of equity when we're thinking about who it is that we're studying. This is an ongoing R01 that we're doing now, just to show you that we're continuing to try to move forward. Our transgender individuals report the highest degrees of discrimination and stigma. That's the top left. On the top right, you can see the staircase effect in terms of depressive symptoms, such that transgender women are reporting the highest degree. And then again, those purple dots are the transgender women, such that on a mechanical stimulus on the left, a heat stimulus on the right, these are pain-promoting stimuli. The transgender women are reporting the highest degree of pain sensitivity. So we're trying to flush out these pain sensitivity differences as a function of social experiences across transgender men and women, right? And then also as a function of hormone replacement status and transition status, and we're getting into that. I want to say we're either waiting on hearing or we just heard about a supplement to add binary individuals. I'm not sure why I said it with such an accent. Non-binary individual. Thank you. All right. Yes, non-binary individuals into this mix as well, right? Because again, we want to be inclusive. So to wrap things up, people will say, Burl, you know, like, why do you seem to do so well, like engaging these communities and recruiting these individuals? And frankly, I don't know. Like I'm a white guy. I don't know if I would trust me walking into your community, right? But 3 sort of philosophies in my sort of laboratory, and just in terms of how I conduct business, is 1, we pay people well for their time to come in, right? So this is their time. Time has value. Pay them accordingly. Provide a service back to the community, even if it isn't directly related to what it is that you're studying, and then engage and support communal resources that are already in place, meant to help the people that we care about, right? What might that look like? My back pain study here that we've been working on. Over the last 6 years, we've enrolled about 500 participants. It's a lot. I feel pretty good about that. Every single one of them got over $500 for their time. So that's a $250,000 investment, right? But well worth it because we have such rich data. If you don't believe me, ask Edwin or Ripley. Like it's amazing how much we've been able to do here. Related to some of the HIV work, there was a mental health gap in terms of being able to provide services to the community. So I went and started a clinical psychology mental health service. And it was, I supervised it and I had trainees that were in there and seeing patients, so forth and so on. And then now one of my former trainees who is back as a faculty member at UAB now runs this clinic and it's still going. Again, that's not necessarily directly related to our research, but it's super important. That's a service back to folks that we care about. And then last but not least, for the study that we have that's focused on the sort of cisgender, transgender, which by the way, we call sex hormones and identity affect nociceptive expression, SHINE. You got to have a cool acronym. We engage Birmingham AIDS Outreach and Take BHAM, and Birmingham AIDS Outreach has the Magic City Acceptance Center as part of it. Take BHAM is Transgender Advocates Knowledge and Empowering, right? And these are two community groups that we liaise with. They've come and given sensitivity trainings to our teams, which have been good. And we've supported sort of some of their local efforts. And we actually now have like university approved contracts with both groups such that each year we provide them a bolus of cash. And then we just say, use it as you see fit, right? It's not contingent upon meeting our recruitment guidelines or whatnot, right? It's meant to support your mission because we're a team here, okay? So that's what we do. That's what we're trying to do. That's the team I work with. That's how all this lovely data gets done. I wouldn't actually be standing up here if it wasn't for my wife, who's made lots of sacrifices, taking care of these kids. Here's my funding acknowledgement. Love all these funders. And the NINDS one with the question marks, I'm going to direct that towards Laura. She knows what I'm talking about. And I will wrap up with that. Thank you, folks.
So it's my pleasure to be able to introduce you all to Cameron Young. Our final speaker this morning will be sharing his story, Growing Pains, what I learned from growing up with chronic pain. Cameron is a high school senior from Madison, Wisconsin, and has experienced pain for his entire life. He's worked with multiple different advocacy organizations, including the U.S. Pain Foundation and the Ehlers-Danlos Syndrome, or EDS, Wisconsin. He's also involved in activism for other marginalized communities and is passionate about the disabled and transgender communities. So Cameron, we're really excited to have you here.
Thank you. Can you hear me okay? Okay. When you decided to attend this conference, you probably didn't expect a high school student to be one of the speakers.
Glad you are.
Thank you. Having been an adult for just 2 months and having no research experience, what could I know that you don't? In terms of actual science, not much. But I do have insight to provide. I've been diagnosed with Ehlers-Danlos syndrome for 9 years, so I've had symptoms for as long as I can remember. And as you might have guessed, getting diagnosed with a rare and underdiagnosed condition wasn't very easy. As you might have also guessed, finding treatment, especially treatment that actually worked for me, was also not easy. The thousands of hours of doctor's appointments, hundreds of medication changes, referrals to new specialists, and ER trips would be complicated enough on their own, but they were made even more complicated by the things that make me different. The most obvious difference between me and the typical person with chronic pain is my age. Getting diagnosed at a young age, while crucial for treatment, is a long and complicated process. When I was a baby, my mom notes that my back would crack when I was picked up, and at 3 years old, I complained of knee pain when I walked more than a quarter mile. At 5 years old, I heard the words Ehlers-Danlos syndrome for the first time. My pediatrician was pretty sure that it was EDS and referred me to a specialist, but the specialist told us that I was simply too young to diagnose. It took another 4 years of worsening symptoms for me to finally be able to see a specialist again, at which point I was finally diagnosed with EDS at age 9. It was a relief to get a diagnosis, but we quickly realized that EDS adds on an additional layer to every medical concern. Each new symptom had me guessing if it was something normal or more complicated from my EDS. On top of my uncertainty, it was nearly impossible to find a doctor who could actually tell me confidently what was going on. And when I needed to see different doctors for any reason, I would often have to choose between a pediatric doctor who didn't understand chronic pain, or a doctor who might understand EDS, but wouldn't know how to work with children or understand how my age would affect my condition. Chronic pain disorders in kids are generally misunderstood and sometimes even unknown simply because it's not what people expect. For me, this lack of understanding of EDS, even by doctors, was frustrating and often prevented and slowed the treatment of my symptoms. Youth with chronic pain are often written off as just attention-seeking, being dramatic, or complaining too much, or told that they're just experiencing growing pains. And this sometimes even leads to them keeping it inside and not telling anyone about their pain to avoid being criticized. Growing up with chronic pain means not knowing when your issues are serious enough to actually be taken seriously. So far, I've only talked about how being young and having chronic pain have impacted my experiences with healthcare, but there is another big thing that's affected these experiences. I am transgender, meaning I was assigned female at birth, but have since transitioned to male. In a perfect world, being trans wouldn't affect how anyone is treated, but unfortunately it often does. Many trans people have horror stories of treatment by everyone, but most relevantly to this, their doctors, which shouldn't be a thing. But in my 7 years of being out as trans, my personal experience of healthcare haven't been severely impacted by transphobia, but there have still been small moments. Small things like getting judgmental looks from nurses when they see testosterone on my medication list, being misgendered early in my transition despite my medical chart noting my pronouns, and the wrong name being called in the waiting room despite having it listed as my preferred name. Whether intentional or not, these are the types of small things that deter people from seeking the healthcare that they need. In addition to this social treatment, there's another layer of complication regarding trans people receiving healthcare. Similar to the lack of medical understanding of youth with rare conditions, there is a huge gap in understanding when it comes to how being trans interacts with disabilities in medical treatments. I've experienced this numerous times personally and heard even more from others about it. For me, the first thing that comes to mind is how none of my doctors could actually tell me how being on testosterone would impact my chronic pain. My gender specialist didn't know much about EDS, and my pain specialists didn't know about being trans. When trying to decide what steps to take regarding anything medical, it's crucial to know the benefits and risks. When it comes to transitioning, people with any type of condition often have very limited information about how the two things will affect each other. The lack of information about EDS and other rare conditions from both doctors and everyone in general leaves people with these conditions just guessing what is and isn't normal. It leaves patients in the vulnerable position of just having to hope a proposed treatment or medication will work, or hoping that a symptom will go away on its own. I've dealt with this more times than I can count. For example, when I got my wisdom teeth out just 2 months ago, despite the physician being extremely knowledgeable about EDS, which is already in itself a very rare thing to come across, we still weren't sure how my EDS and other conditions would impact my healing. Multiple infections followed that procedure to the point that I had to get another procedure a few weeks ago to hopefully stop the infections. And I'm still not in the clear now, months after the initial procedure. With EDS, I never fully know what to expect from anything, and neither do my doctors. When I was first diagnosed, I had a lot of questions, and medical professionals had very few answers. So who do you turn to when even medical experts don't know how to help you? For my family, we found other people with similar issues. Immediately when I was diagnosed, my parents started joining EDS Facebook groups and connecting with other parents of kids with chronic pain. Through meeting various people, our family was brought into a community made of people with chronic pain and their supporters all helping each other. The people we connected with over the years helped me more than I could express, giving advice when I needed it, providing resources, and most importantly, understanding me. My family and I realized how valuable these connections were for all of us, and after a few years, we decided to create a local support group for people with chronic pain. We soon realized that there were way more people with EDS and similar conditions in our small town than we thought. Each meeting, we needed more chairs than the one before. These meetings provided an opportunity for people to share their experiences, advice, worries, and suggestions for treatments and EDS-aware medical providers, and get to know other people with similar conditions. Through these meetings, I realized how social supports like these can greatly improve your medical care, and how your medical care can in turn improve the social supports. On many occasions, people learned about treatments, medications, procedures, and other medical options, which they then told their doctors about. And in the same way, many people either learned about or received some kind of treatment from their doctors and then told people in the support group about it, giving them options that they wouldn't know about otherwise. Social supports and medical treatment are way more complementary to each other than people realize, especially for people with rare conditions. Having a rare pain condition as a young transgender person has made for a pretty difficult journey. It's a journey I never would have chosen, but it's taught me a lot. If I could summarize what I've learned through my journey into one message, it would be this: connection creates understanding, and understanding creates solutions. Being here with everyone today, I think we'll make great connections during this conference, and these connections will lead to great solutions. I appreciate this opportunity to share my journey with you all, and thank you to everyone who helped with organizing this event, and thank you for all coming and trying to improve the lives of people like me and for listening to what I have to say. Thank you.
Can you please come back for one moment? I just want to thank you so much. I'm not going to get emotional, but we truly appreciate your time, your family's time, the contribution that you come here, the insight, your unique experience, the challenges that you experience, your willingness to come and share that with us in this stage at your age, which is, wiser, you're wise beyond your years, because of the many challenges you faced. But we thank you, we appreciate you, and we wanted to show a token of our appreciation with the certificate of recognition, because we think we might have broken a record with one of the youngest keynote speakers. And we're not sure, we're not going to check, but it doesn't matter right now. So this is our certificate of recognition signed by our director of our institute. And just want to thank you, and we appreciate you. Thank you.
Well done.
Okay. Yes, thank you so much. So again, get to know each other. This is a fantastic group, right? As you can tell, I hope you see how those keynotes have set the stage for what our charge is for this afternoon, to really get deep into some of these discussions around these areas. And so this is my transition to breakout slide to tell you to grab some snacks first. Those snacks are gonna leave. We brought paper bags, so you can pack snack bags to take to your breakout rooms with you so that you'll have snacks, because there are no concession stands, there are no vending machines in this building, okay? And then once you find so then the second thing is finding your breakout room. So the multi-level interventions panel is gonna stay here on the first level. You have the easiest job. You just have to go next door to room 1275. And Karen, can you stand up, please? So Karen is the NIH facilitator. She will be in 1275. Okay, so, and then the community engagement panel is on the 5th floor. We have Marlene. Marlene, can you please stand up? Thank you. She is the NIH facilitator. She'll be going up to the 5th floor, so you can follow Marlene if you're in the community engagement panel, or other people that have this blue NIH staff badge. They will help you get there. And then the 6th floor is the workforce panel. It requires a badge. You will definitely have to follow somebody to get there, to open the doors to the 6th floor. Okay, then take your bio breaks, but don't forget to order lunch. The information should be in your folders, okay? Because the lunch is going to be delivered downstairs. So if you order it now before we get started, it'll be here in time for lunch, okay? All right, thank you, everyone.